Hello, everyone. Today I have Dr. Alex Ghasem, who is a spine surgeon in Southern California. How are you doing, Dr. Ghasem?
I'm doing good. I'm doing good. How are you doing today?
I'm doing great. All right, let's get
Thanks for
started.
having me.
Yeah, of course. Let's get started. What inspired you to go into medicine?
That's a great question. I mean, honestly, it's one of those things that I actually knew I was going to be a doctor from a very young age. I had family members that were in very destitute areas that had very poor access to healthcare. And it used to be the era of house calls for physicians. And so anytime I remember a doctor would come into my extended family's house, it was a really big deal. And they made breakfast for him, and he was really treated like a hero. And so I really wanted to have that be my life and, take care of people, be a hero for them, and be an advocate for my patients. So from that point on, I knew I was going to be in medicine, and then the rest kind of worked itself out in a few different acts of the same play.
Yeah, that is not a story I hear very often of the house call.
What is the most common story? I don't even. What do most people say today?
Usually it's a family member who had some kind of illness, or they had some kind of illness. I mean, basic stuff, I guess.
Uh-huh, uh-huh. Cool.
Yeah.
Good.
So why did you specifically choose to do spine surgery?
Yeah, it was really a long road. I mean, I think a lot of the stats, if you look at it, comes down to suggesting that about 80% of medical students who enter school have an idea of what they're going to be, but they're actually completely wrong. So they end up coming in thinking they're going to do one thing, and they leave going into a totally different residency. And I was part of that 80%. Honestly, I had several changes in terms of what field and profession I thought I was going to go into. I ran, from cardiothoracic to ophthalmology, and for a long time I thought I was going to be a surgical oncologist. Um, and I remember one day I just was getting tired of a lot of the patients passing away so quickly on the surgical oncology side, and I said, you know what, I'm just not wired to, reap the benefit of giving these people a little bit more dignity in terms of dying with some dignity. And so for me, for going from that experience and then finding orthopedic surgery, where you have somebody who comes into your office in a wheelchair, you do a hip replacement on them, and they walk out the same day, and you have right then in that moment changed the trajectory of their life for the next 20, 30, 40 years, is really a magical experience that I think resonates with a lot of people who need some more instant gratification. And then I think the rest of it comes down to my time down in Atlanta. When I was in Emory, we actually had I was doing a lot of sports-based surgery. I was following a lot of the guys who were taking care of the pro athletes. But I ended up finding people who were just really great spine mentors for me, and the surgeries were really impressive. And that same characteristic of how a hip replacement can change your life. In medicine, we quantify that in a term called QALYs, but looking at how your life years can be impacted by simple events. And, with a simple discectomy, that's probably the next closest thing I would say to a hip replacement. And so the spine surgeries were just so awe-inspiring when you watch them, and you still got that gratification. So along with some mentors, I ended up going into spine surgery at that time.
Yeah, I've talked about this before, but patient outcomes is something that not many people going into medicine really consider. They think like, oh, I'm going to go into neurosurgery, and then they don't see on the outside that everyone gets admitted to the ICU, and they're very, very incremental stages in getting better, and sometimes they don't. And like ophthalmology, as you mentioned, and orthopedic surgery, when they wake up, or even maybe a few weeks later, they are their lives are changed because they can walk, they can see, they can hear, they can do
Exactly. Exactly. You don't just, you really don't even just impact their vision or their function. You impact every aspect of their life, their relationship with their loved ones, their psychology. The whole trajectory of their life is completely altered for the better in most cases.
Yeah, absolutely. So you talked about being at Emory, right? That's a very prestigious school that I'm sure took a lot of work to get into. Do you have any kind of, tips for the pre-med or the medical student who's looking towards a very selective school?
Yeah, I think that the paradigm and the target is always moving for what the med schools are looking for. I don't work as much with medical students. Sometimes we do have people who come shadow with us, or I have some residents or fellows that we sometimes work with at Cedar Sinai. But I think the main kind of meat and potatoes of what your application always consists of is going to be, um, how you do in your testing, your grades, and your research background. Some extracurriculars I think are important. And a lot of it is also who you know. Do you have a great mentor that can stand up for you and say, this person is tested, they've really done well, and I know that they're going to be someone who flourishes in your institution. And if you have the opportunity, some kind of a special circumstance where you can actually go and spend time with someone from the institution, if you know where you want to end up, who can come in and vouch for you, I think that makes a huge difference. Something that's not really tangible or that you can't really palpate that on paper. But I think that those are the really critical things. And then I think that your ability to communicate and articulate at the interview stage is also something that everybody's really looking at, because I think now more than ever, medicine has changed much more towards patient autonomy as opposed to an authoritative model where the physicians are just dictating what happens, and it's much more of an interaction. And so a lot of medical schools, at Emory being one of them, is they really place a strong emphasis on your bedside manner and your ability to communicate.
Yeah, I've also seen that more recently, is that that's a thing that people are looking for, of the bedside manner and the communication. Because if like these new requirements, I'm not sure if you know, but like Preview and Casper, it's all about like, how do you talk to someone who is a patient? Yeah. So let's talk about mentorship again, that you were mentioning. How how important is it for someone to go find a mentor?
I think it's, especially in a field like medicine where you're always developing, you're always growing, you're learning, you will make mistakes, you will have great successes. Having people to help you guide and share that with, especially in surgery, but in any field, I think is actually absolutely critical. And you may have multiple mentors that you learn and capture different things from each of those mentors. You may outgrow some mentors. Um, but I think it's absolutely essential to have somebody that has been where you are, even to give you some peace of mind when you talk with them is absolutely essential, um, and to help you pick you up through some of those dark corners in medicine, because it's not all fun and games. There are certainly, especially the higher stakes surgical fields, you're playing a little bit with fire sometimes, and if you get burned, it's nice to have somebody there who you can talk to who's been there, and point you in the right direction. I always say good experience comes from bad experience, and so getting some of that bad experience without having to live through it uh, can really save you some headache down the line. Actually, I remember one of the deans in my medical school probably gave me the best advice I ever got through my training that I remember all the time, which is he said, you're always going to have a mountain of work in front of you, always going to have things. You're going to be standing at the bottom of the mountain. Don't look at the top. Put one foot in front of the other and make sure that you're basically looking at the patient in front of you. Take care of the bandage on the patient in front of you. Don't worry about everything else. Everything else will work itself out.
Yeah. And for medical students, that's a big tendency, is to look at the next challenge and keep looking forward, which can be overwhelming, instead of focusing on what is in front of you and what you can do right now to advance your career forward.
That's exactly right. You want to have obviously kind of a bigger global picture and making sure that your goals are still aligned and you're heading in the right direction on kind of a macro or bird's eye view type scale. But be in the moment. If you're taking care of something, give it 100% where you are, so that the quality of your work and that experience doesn't suffer or doesn't pass you by.
Yeah. I've had a few medical students say that when they're looking for a mentor, just reaching out is the most important step, and the physician will most likely give you a positive response, or they won't like tell you go away, like I'm not looking for someone to mentor. How much truth is there in that?
It's a good question. Honestly, I think that there are certain things that a mentee needs from a mentor. Obviously, guidance, experience, sometimes help in getting to the next stage in their careers. But there's also the other side of that. I think a mentor also has certain expectations of people that they take under their wing. They have to be qualified. They have to show effort, and people want to show. I would say that people want to help others that they see want to help themselves. And so if you're dedicated to your craft, if you're always on time, if you anticipate, the next thing, if you can show that you want to help and really emulate what the mentor does, then I think most people want to make time for that, because original physicians back, in Roman era and even before that, have always been regarded as teachers. That's really what they are at their core basis. Everybody loves to educate. They love learning knowledge, but also passing knowledge along. So I think if you prove yourself to be a worthy mentee, then people will want to take you under the wing. But it's not just sending an email and saying, "Hey, can I be your mentee, or can I follow you around?" It does take some effort, persistence, and discipline to really catch the mentor's eye as well.
Yeah. How can somebody demonstrate that they are a worthy person to be mentored?
I think it's the things I say. I think it's anticipation is one big thing. If let's say someone gives you a shadowing opportunity and you see that every time someone comes in for a myelopathy examination for the cervical spine or thoracic spine, and you know that the doctor has to go and get a reflex hammer. If you show up to the door with a reflex hammer, he's going to remember that. He's going to say, "Oh, this person is actually engaging in active learning, and they're interested here. They're not just here to add something to their CV. They're here to actually contribute to the practice, to the growth of the practice, but also for them to learn something, and they're actually interested." And I think that that's what really every mentor is looking for when they pick someone up, is someone who's smart, worthy, but also just shows a lot of interest and effort.
Yeah, absolutely. Being willing to learn and showing that you're willing to learn just gets you so much further than just being passive and waiting for someone to tell you that this is what has to be done and things like that. That's goes for like everyone. I've talked to a registered nurse and he said the exact same things, that if you can show that you're willing to learn, then what do you say? If you show you're willing to learn, then the physician will be much more open to inviting you and asking you to be like in the operating room or in the emergency room or something like that.
Exactly. Exactly.
Let's talk about spine surgery specifically a little bit more.
Let's do
So,
that.
what kind of pathologies or conditions do you see on a day-to-day basis?
We see everything. Honestly, I recently stopped taking it, but I was for a while taking level one spine trauma call at Cedar Sinai. Um, and so we were seeing some really bad spinal cord injuries, which is basically kind of acute neurologic deficits, sometimes paralysis, a lot of spinal fractures, sometimes infections, tumors, those kinds of things that happen in the spine. Most of what we take care of now is what we call, some deformity or kind of scoliosis type stuff, but a lot of it is mainly degenerative pathology. So things that happen to the spine as we get older, or if we have an acute injury to the spine. So, um, an athlete picks up is deadlifting, picks up a huge amount of weight and blows out a disc, has a massive disc herniation, has horrible pain in their back, their legs, they're losing motor function, numbness and tingling. Sometimes their ability to go to the bathroom is affected. So those are things that we often see in the clinic. There's the other side, which is what happens to your spine as you get older. So we have another part of the curve that's more, patients in their 50s, 60s, and older. Just like you get your knees wear out, your hips wear out, your spine also wears out. So we talk about knee replacements, hip replacements. We do things where we do fusions, where we stabilize motions segments that are basically too mobile, they're moving too much and causing patients pain. Or sometimes the arthritis kind of grows into the space where the nerves are along with the discs and causes nerve compression. And the patient's getting, again, numbness, tingling, weakness. And we have to go in and relieve that pressure so that the patient isn't dealing with as much pain. So we're dealing with less emergent cases. I mean, we still see, infection cases, sometimes fractures and trauma cases, but and sometimes spinal cord compression, which we call myelopathy, if it presents to you in the office. But a lot of times we're dealing with issues that are quality of life problems that are just making life very miserable for people. And so we deal with that through opening more space for the nerves or gluing bones together, which we call fusions, to stabilize segments that are otherwise causing problems for the patient.
Yeah, there's a lot to unpack there. Let's start with what you said about neural deficits when they come in with severe compression. How often do those people lose their ability to walk? And if they do, what can you do as a spine surgeon to help get that back? And let's say they don't, how do you deal with that as the physician and even as the patient?
Yeah. The amount of time we actually see someone gradually lose the ability to walk is not very often. We'll see people who come in with weakness. Maybe they have a foot drop and, a painful foot drop, and we relieve pressure from the nerve, and then they rehab that, and then they are, good to go. The times where we see paralysis, sometimes we have something that's called, or more acute pathology, but sometimes we have something called cauda equina, where the nerve roots at the base of the low back are very tightly compressed, and that can cause some motor problems and make it difficult for people to walk. But most of the time when you see that, it's more of an acute spinal cord injury that leads to more of an acute presentation of spinal cord compression and paralysis. Or, sometimes I have, people who have fallen off of buildings, or they've been into terribly severe car accidents, or they've been, they've sustained gunshot wounds that have impacted the spine. Those are the patients where you usually see paralysis. And, it depends on how severe the injury is and how quickly we get to it. And that's a lot of what impacts their prognosis, how well they do, their ability to regain the ability to walk. So that's not as common as you would maybe think, but it is certainly something we see not infrequently.
Yeah, I mean, that is kind of good to hear that you don't, that is a little infrequent, patients getting paralyzed after trauma.
Yeah.
Now let's go back to the degenerative kind of portion of spine surgery.
Yeah.
Obesity, and under my understanding, is a big problem for spine degeneration and overall spinal health and total health. But now we're seeing the GLP-1 agonists start to gain a lot of popularity. So, as a spine surgeon, do you think that that is an overall good for the health of patient spines and their total health, or does that kind of throw a wrench into the works?
I'm not, I don't want to come and promote GLP-1 agonists. I mean, there have been some that have been around for a long time, even before Ozempic, and some of the other brand name guys that are now on the market. Um, but I do think, just from a spine health perspective, one of the things we always talk about, I have a lot of patients, golf course, professional athletes, ballerinas, and stuff like that have gone past their career and say, what do I do long term for kind of my overall spine health? How do I protect myself in the future? And weight loss is a huge thing. I mean, if you think about it, especially our lower back just takes such a beating and is basically the pedestal that the rest of our torso stands on. And so reducing that axial load through those lower disc spaces makes a huge difference in terms of the force administered and the rate at which everything wears down. So I would say, in general, weight loss is critical. Keeping your core strong is very important. And then for overall disc health and joint health, it's important to reduce any type of nicotine or smoking intake that you do. Those are usually the three things that I tell people are really important. So to answer your question, absolutely, obesity is a problem. Keeping your weight down in whatever means necessary will help your spine. Now, whether that's through exercise and diet, or GLP-1 agonist, or if that's through bariatric surgery, those are all options that you have to discuss with your primary doctor as well as your surgeon.
Yeah. What I have seen, though, is people taking these drugs before surgery, and the anesthesia gets kind of, I guess, messed up is the right word, because it slows down your motility. Does that play a role in your practice?
It does. It does play a role. Now we have to counsel patients on when to stop their Ozempic or their Wegovy to be able to proceed with surgery. I think initially it was more of an issue because surgeons and the anesthesiologists weren't talking as much, and so they we weren't aware of the gastromotility issues and the risk for aspiration that takes place. So that was certainly something that was canceling or rescheduling some surgeries last minute, because we didn't find that out until the anesthesiologists were telling us the morning of surgery. But it's just something that you prepare for in the preoperative time span, just like rheumatoid medications or blood thinners, and you just add it to the list now, and it hasn't really been much of an issue if you stop it at the appropriate time.
All right, that's good to hear, I guess. So, a common question that I see is, what is the difference between a spine surgeon who did an orthopedic residency and a neurosurgery residency?
That's a great question. That's a great question. So this difference in the spine surgery used to be that the hardware, instrumentation, fusions, scoliosis correction, was all handled by the orthopedic surgeons. They were more familiar with instrumenting, with screw placement, etc. And the neurosurgeons were more adept at the more kind of delicate or decompression, handling of nerve roots, etc. But in modern day spine, there's now been much more of an integrated training program, so that both sides are learning kind of both styles of techniques, and it's really just becoming one field that's very integrated. I would say really now the only thing that is different is that the neurosurgeons, if there's an intradural issue, which means that all of our nerves are held within a water balloon, that we call the thecal sac, or inside of the dura. And inside that water balloon, sometimes things can happen. You can have, rarely infections, but a lot of times you can have tumors that grow into that space. And the neurosurgeons will still go inside of that space in the water balloon, but the orthopedic surgeons will stay just outside of the water balloon. So that's really the only difference now. But both of them are doing, fusion operations, disc replacement surgery, and decompression surgery as well.
Yeah. Would you say that that kind of goes the other way around of, like, let's say someone has a tumor on the vertebral body itself, then that would be more of like an orthopedic issue rather than a neurosurgery issue?
I would say that maybe a long time ago that was the case. It would probably be that the orthopedic guy may consider that. They may consider, depending on where it is and what the issue is, an instrumented corpectomy, and that was certainly something that was much more, orthopedic based, some time ago. But now I would say, either party could handle that, or should be able to handle that, if they've been trained in the last, several years.
Yeah. So what is now the most common thing that you do? You said all these amazing things of deformities and intradural tumors and decompressions and stuff, but what do you personally see most often?
Yeah. I would say the most common surgeries that I'm doing now, and I think a lot of that has to do with the marketplace driving that in combination with where the medical indications are going. But I practice in Los Angeles and Beverly Hills and the surrounding area, and the population's very educated, and they want to avoid fusions. Fusion is actually a great operation, but there are some restrictions with that, and so people are preferring motion-sparing operations. So, I'm doing much more disc replacement surgery than I had ever been trained to do in the past. But that has really become one of the prominent and predominant surgeries that I do, is cervical and lumbar disc replacement surgery for the right people. And so we've kind of built our expertise in our practice around cervical and lumbar disc arthroplasty, or disc replacement surgery, I would say, is the most common surgeries we do now.
Yeah. And talking about before, trying to preserve movement, what is like the role of the non-operative care with like PT or medications, I guess? I'm not really sure. So
Yeah, everybody is, except in the setting of problems where we know they're going to continue to get worse. Like I was talking about, cervical or the thoracic spinal cord compression, where we know the more time we wait and the further neurologic deterioration we see, that the patients are going to continue to get worse. So we have to step in. But in every other scenario, in general, surgery is the last case resort in that setting. So we like to try all of those things: physical therapy, stretching programs, medications, and these other analgesics or pain modalities are great for enabling the patient to try to make maximum effort when they go to therapy and really try to improve their mobility in those scenarios. So absolutely it has a role, but to a certain point, because there is certain just anatomic constraints that cannot be corrected through therapy or muscle movement. It's really something that has to be opened or resected to be able to create that space or mobility.
is there ever a time where that non-operative treatment actually worsens somebody's condition?
It can worsen their pain. I'm not sure I would say that the therapy necessarily worsens their condition. There are some reports and case studies of, adjustments or some hyper movements that can cause neurologic or vascular injuries if you do rapid movements or hyperextension or flexion movements. You can certainly cause neurologic or blood vessel dissection or injuries that is certainly possible in patients who are predisposed to those types of injuries.
I'm going to assume you're talking about chiropractors right now.
I'm talking about chiropractors, but honestly, if anybody starts, moving your neck in a really aggressive way, and you have significant already baseline spinal cord compression, you're at risk for injuring your spinal cord. Yeah.
Do they play, and I guess I was going to say important, but do they play any role in spinal care, or do you see them as like something that might exacerbate a really bad like compression or herniation or something?
Listen, I think we see people who certainly with time, with massage therapy, with heat and electrostim and different kinds of things, they just need some help with getting back to activity and, getting over the spasm and the pain of some of the conditions that they have, and allowing time and some other modalities to get them over the hump. So I think that they can certainly have a very productive role and help patients. But that treatment, just like any other treatment, has a ceiling to what it can accomplish. And there are certain things that no matter how much medication or therapy or adjustments you do, you're just not going to get better, and further treatment is needed. So I think that they certainly have a role. I don't mind. I think that they're a great starting point, as long as you've made sure that your imaging shows you're not at high risk for a neurologic injury. Then I think that they can be of help. But I think that any treatment has a ceiling, whether that's chiropractic care or anything else.
Yeah. I've seen people on both sides think that like chiropractic is just like pure voodoo, and the other people that think it's just like the most magical thing that they've ever had.
Yeah.
So,
and that's great. I mean, honestly, they certainly help people, and even if there's even a small amount additionally of placebo effect that goes along with that, that's great, because all you really care about is how is the patient doing, what is their outcome, are they happy, and has their function been restored. So I think that they do have a therapeutic or medicinal, help in certain situations or effect, and I think also the patients just feel better having someone take care of them, touch them, care for them, and that's a very powerful treatment tool as well.
absolutely. I think even just being seen by someone who has like a modicum of knowledge of medicine really puts people at ease. Except if you have like white coat hypertension, but we don't have to talk about that.
Yeah, exactly.
So being in Southern California, something that I've seen when I'm working at like urgent care is people like to treat the clinic like like a shopping mall, basically. Like they know that they can get like a Toradol injection. They're like, "Can I get a Toradol injection, please?" And of course, we give it to them if there's no like contraindication. But I'm sure when it's somebody's like back and their spine, it can get a little bit worse. Is that something you see? And if you do, how do you kind of go about counseling the patient about that?
It depends on what it is. If I understand your question, you're saying that if someone brings to me a treatment modality that they think that they need, do I just give that to them? Is that what your question is?
My question is, let's say somebody comes in and they want like a disc replacement, right? But their condition is not really warranting full-on surgery. They can probably do some physical therapy or some other non-operative treatments, but they're coming in right now and they're like, I want that surgery right now. I don't want to do anything else. How does that conversation go?
Yeah. I think urgent care is more of like, it's a little bit different medicine. It's almost like retail, and very directly fee for service. You come in, you need this, and if it helps them, and they think it's going to help them, then absolutely, I think you give it to them. Surgery, I think a surgeon has a lot of variables that goes into the formula. You really have to always do what's best for the patient in that moment, and you can't let the patient tell, kind of, just like it's an interaction. there's two parts to that equation. The patient voices their needs, but ultimately you're the gatekeeper to treatment, and you have to do what you think based on your medical knowledge is best for the patient. So I'll tell you, I had a guy who flew in to me from New York, and he said, I saw your stuff. I want a lumbar disc replacement, and I want it, while I'm here this week. And he was not a candidate for a lumbar disc replacement. I looked at his scans, and I remember he was kind of upset that I told him, I said, you're not a candidate for this. And the way I framed that for you is saying, hey, if I do a surgery, I don't want to have you come back and sit in the room with me and say I'm no better or worse. And you've had to go through this recovery, taken all this cost, had people, come in to support you, maybe lose your job. All of these things, people sometimes think of surgery as a magic wand that fixes everything. And I have to do what I believe is best for the patient based on my medical knowledge and my expertise. And what we often say is, if you've come to me and you believe that I'm the right pilot for you, then let me fly the plane. That's the bottom line. So if there is something that I think will help the patient and is in their best interest and they want it, perfect. Then we'll do that. If it's something where they're suggesting something that I think does not have clinical benefit and may harm them, then we're not going to do that.
Let's look at it from the other side of somebody's coming in and they're like, my back really hurts going down both legs, and they really don't want surgery. But you see that surgery is basically the only way that they can get better. How does that conversation go?
That's actually a much easier conversation. That conversation usually goes that I basically tell them that the quality of your life, the way you're living, has to become so bad that the anxieties and the fears that you have to be outweighed by that potential, benefit. You have to be in such such a functional dilemma that you're willing to overcome those anxieties. So people, honestly, what we say is time helps declare everything. That patient usually may say, I'm still not sure. And they may sometimes ask us for a psychological referral. At the end of the day, that patient will be back. If they have had to deal with that for enough time, then they'll eventually come back and say, listen, I've tried everything. Let's go. And then you want your patient always to be on board with your treatment plan. You want them to buy into that. You don't want to be pulling them into the operating room. That's the biggest mistake you can potentially do. So I take this quote from Bruce Lee all the time. He says, pain is our greatest teacher. And when these people deal with the difficulties day in and day out, eventually they're saying, okay, I'm in your hands. Let's do this. I'm willing to take these small risks for the greater good and greater gain for myself.
Yeah. How risky is spine surgery? I imagine it's something done very commonly, so there's been ways to mitigate it. But if someone is anxious about going into spine surgery, how risky is it actually?
That's a great question. Every spine operation has its own sets of risks that come along with it. The way that I describe it, we'll pull one operation. Let's say we're talking about a cervical disc replacement. People often come to me and say, can I be paralyzed from this operation? That's a lot of the times what I get. And what I tell people is this: you have to understand the difference between complication severity and complication incidence, or how often does that complication occur. What I tell them is, to give you an example, let's say you are going from California to New York. Do you walk to New York, or do you take a plane, and do you fly to New York? And everybody's going to say, well, of course I fly. And I said, but that plane can crash, and you can, fall and from the sky, and you could, pass away. But you take that risk. Why? Because the plane provides such a service for you, and the risk actually of the plane crashing is so low that it's almost nominal and it doesn't really matter. And some of the things that we do are, so I think about complications to answer your question in terms of severity, how can that really impact a person, and how often is the actual likelihood of that occurring. So for paralysis, let's say it's obviously a very severe complication. The chance of that happening is almost zero. Um, so, there are certainly a lot of possible things that can go wrong in any kind of operation. But I think going through that very carefully, setting the expectation, how likely is this? What can you expect? And what I like to do in the office before the surgery is I like to sit down with patients and really paint them a picture of what they can expect. I give them the most common things that happen. For instance, having some sore throat or swallowing after an anterior neck operation is very common. It's over 90% approximately of patients that do experience it. But it's a very mild issue and it goes away after, a few days or a week or so. So, weighing severity and incidence, setting the stage, the expectation, saying you're going to have a little bit of swallowing difficulty initially, but that's going to go away, and saying there aren't bad things that can happen, but those things are very, very unlikely to take place.
Yeah. And that just reminded me, like stupidly, of the Dr. Death documentary. That was, I'm smiling because I thought that was funny. I came up with that, but oh my God, that was an awful, awful, awful show.
Yeah.
Or documentary. Anyway, my bad.
Yeah, you definitely have to be careful and, do your homework on who you put your hand, put your health in, whose hands you put your health in.
Yeah. And that show, and there's this other show called Bad Surgeon, who was a cardiothoracic surgeon who was doing trachea replacements, and everyone who got it died, right?
Yes. That was on Netflix too, right?
Yeah.
Yeah.
I think people, when they see things like that, their trust in doctors goes way down because they see that show and they're like, oh my God, that could happen to me. That's kind of like the plain analogy you gave of it's something uncommon, but it can deter some people from going or seeking care because they've seen some horrific examples of medical malpractice.
Yeah. A lot of the media, for excitement factor, for a lot of reasons, and just society, I think, is really starting to vilify physicians and surgeons, maybe partially related for cost-related issues, but for a lot of reasons that we can go into another time. But what I'll say is that you absolutely, when you put your health in someone else's hands, you need to verify that they are qualified, they know what they're doing. But aside from that, I want to say that the vast majority of physicians got into the field to help people. They're not there to, have, profit and have some kind of a device that they just make money and harm people for. It's really, they're there because this is a profession that helps them derive purpose. They're all very bright people. They could have gone into other things that was more finance geared, and fiscally, rewarding for them potentially. But they do this because they're there to help people, and they really are heroes for the most part.
Yeah. You mentioned at the beginning of the doctor coming to the house and they were the hero. They cured probably your family's illness. With the aftermath of COVID and shows like that, there has been like a massive decrease in physician trust, in like physicians feeling like they're heroes, they're saving lives, they're helping people. What do you think about that trend, and how do you feel personally about being the hero, I guess, of patients who are either distrustful or ungrateful or things like that?
You know, I don't see that as much. If someone, the way I look at it, and I don't let that stuff impact anything. The way I deal with medicine is it's just being handled by the people in the room. I don't worry about the insurance companies. I don't worry about the media. I don't worry about any of those external factors. I'm dealing with the person sitting immediately across from me, and I have to believe in every single room that I walk into that that person has come to me because they need my help. And that's how I view every single one of my patients. And it's a normal reaction to say, I'm concerned about the surgery, but all you can do is give them the information and explain to them how it can potentially make their life better. And then you put it in their hands. So, you know, I don't hear anything really about, physician distrust. I mean, honestly, for me, after I witnessed COVID, to me, I actually trusted the actual physicians who treat patients more, the foot soldiers. A lot of physicians, they suffered burnout. There was a lot of an increased suicide spike in physicians during that time from the burnout, but also from watching people die. I mean, these people give their lives and dedicate themselves to their patients. And so for me, I don't let any of the stuff, like I said, from the insurance company or the media or anything else impact my relationship with my patients. If they've come to me, I earnestly believe that they're there to receive my help, and I'm going to formulate the plan that I think is best for them in terms of treating them.
Yeah, and I think that is a very good way of looking at it. Of it's just you and the patient in the room, and you are providing them a service, and that's it. That's the only thing that's happening right now. And that kind of goes back to what you said about taking it one challenge at a time, one step at a time.
That's exactly right. Focus on the bandage that you're putting on in that room. That's all you have to think about in that moment. Leave all the social and geopolitical dynamics out of that room. In that space, it's just about you being someone who has a skill set and knowledge that can help somebody else, and that person is there for your help.
Yeah. Kind of piggybacking off of that. What is the most challenging part of spine surgery?
The most challenging part of spine surgery is the high level of acuity and the absolute perfection that you have to demonstrate every single day from a consistency standpoint. If you are doing an operation that if I basically, with the amount of pressure that it takes to press a button in an elevator, if I slip and do something wrong and you can be paralyzed, that is something that requires intense focus every single time that you step in to that arena. So I think the intense focus, consistency, discipline is something that you always have to practice and carry with yourself. The other hardest part, I think, about any surgical space or subspecialty is really that, things can happen to people. Sometimes it's in your control, sometimes it's out of your control, but you carry how your patient is doing with you. So small complications, anything that can happen, those are things that you weigh on, and you're always self-reflecting. Physicians, I always say, are their most harsh critics. And so even if nothing went wrong, but you said, oh, I could have done this a little bit differently, those are things that can certainly pick at you. So it's positive, but sometimes it can be pathologic. The self-improvement process, I think, is important, but physicians are really hard on themselves sometimes, and actually a lot of times unjustly so.
Yeah. And you see that in medical students and pre-meds and almost everyone who's trying to go toward that goal.
Oh, it's just a self-selecting personality trait. You have to, almost be a masochist in that regard.
What did you say? What would you say to someone who doesn't want to be a masochist?
What would I say to what?
To someone who doesn't want to be a masochist.
I would tell them that, try to focus on all the positive things you're doing, like the Wayne Gretzky quotes, and, and Michael Jordan, all these guys, the most highest performers in their industry, those are guys who never worry about the last shot that they missed. They always will shoot again and again and again, as long as they're continuing to improve and stay focused. Because, yesterday, whether you did a great job or you did a bad job, that does not impact anything that's about to happen in the surgery that you're about to walk into. So you have to have a very clear mind and stay positive and keep moving forward. That's it.
Yeah. There was a great Roger Federer quote that was exactly the same way. He was saying, after every point, even whether I win or lose, it's behind me. And I got to focus on the next one right in front of me. This is what I got to put all my energy, all my focus into.
That's exactly right. That's exactly right. It's just small differences that make you, great or excellent. Even I don't know if you're referencing his Dartmouth address, but
Yeah.
he was saying, he only won 54%, of the points he played, but you win the critical ones, and you do that by staying in the moment and not letting pressure break you. And I think that that's really, those are the people you want to trust to take care of you.
Yeah. But hopefully not only 54% of your surgeries are successful.
No, I don't think so.
Yeah. It should probably be a little higher than
Yeah.
Yeah. Tell us about a patient that you will always have with you, either a positive one or an experience that like really changed you.
Yeah. I remember a patient that when I was still taking call at Cedars, he was riding down a hill, young man, married to a very nice young lady. They were, everybody was doing well in that situation, except he was racing down a hill. He flipped over the front of his bike. He landed on his neck, and he was at that time kind of acutely paralyzed. And so I remember, taking it back, talking about all the operation and the recovery path that he would need. And we did his surgery that night. And, his wife was, always bringing kind of gifts and stuff to our office while he was recovering. We didn't know how he was going to do, but I followed him kind of every couple, month to 2 months, and we watched how he was progressing. And now I see him walking again, and gosh, I will remember that guy forever. And that just goes to reminding me why I do what I do. And that's kind of a cementing of my purpose and why I get up in the morning. So, that's a really great patient that I'll always remember for me. I think you always remember the things you wish you would have done differently as well. So, those patients teach us things so that when we move forward, we try to mitigate any things that can happen in the future. So we all remember those people as well. But from this standpoint, I remember these types of patients where you can watch their progress and return to living a somewhat normal life because of how you help them.
Yeah. How's he doing now? Is he walking?
Yeah, he's walking now, and he's doing some writing. He wasn't able to use his arms or hands, and he did such intensive therapy, and I mean, he did a great job on his part. And so I'm just so happy for him and his family, and it's just great to even be a part of that journey, even though I was just a very small part of it, and he did a lot of the work. So.
Yeah. I mean, that is exactly what you said. That's why you go into medicine, is the these patients that come in like acutely ill, or they're not doing well, and from what you do, your intervention, you change their life, and that's like amazing. Yeah. You spoke about that, the rehab, the intensive rehab that he went into. After like a more, let's say, more common procedure, what is the recovery like? What is the rehab like for someone like that?
More common procedures. It really depends on what kind of operation they had. Fusion recoveries are different than simple discectomies versus disc replacement. Everything, you know, everything gets rehabbed in its own special way. But in general, the algorithm is usually more restrictive and then gradually loosening up on your restrictions so you get back to normal activity. I would say for most of our patients that during the initial time span for the first couple weeks, just letting everything cool down is a lot of just walking, staying mobile, getting up out of bed. That's really why you do the surgery in the first place. Regain that mobility, regain that function, but not pushing it too hard. And then from there, we start to do on a graded time scale, we start to advance them in terms of range of motion exercises with physical therapy. And then eventually, once they have the mobility, then we start working on strengthening exercises and really functional tasks that they need to be doing for their job or for their home life and that kind of thing. So it's usually always, we're kind of there guiding them along the way, but a lot of it is focused on reducing the post-operative pain levels and getting them ramped up with therapy and getting them basically back to whatever it takes to get them to their functional baselines.
Yeah, absolutely. And what's the conversation with the physical therapist or the rehabilitation specialist like for on both ends of the spectrum, some similar versus someone who came in like acutely paralyzed?
The conversation is very different. I mean, we have to try to provide them with very specific instructions in terms of what they can and cannot do from mostly a biomechanical standpoint. And then from there, the therapist, formulates a treatment plan within the kind of parameters or guidelines that we provide them. And they say, okay, well, I can fit this exercise in or this, and I need to focus on this. So we kind of give them a framework or a scaffold for them to come in, and then they kind of make it their own. They kind of, add the artwork and the fine finishes to everything once we've kind of built the skeleton for what they can and can't do, from a physiologic or biomechanical standpoint.
Yeah. So it's very tailored to each individual person's needs.
Yeah, it's very tailored, especially when you're getting into these acute traumas and fracture care and all this stuff is very, personalized. And then depending on the patient bone quality and other things, we always kind of are looking at, what a patient can do and can't do and how quickly can we release them out of the cage to really, rehab in a very accelerated fashion. So some patients you have to rein them back in a little bit because they want to do too much too early, and sometimes there's the opposite where you have patients that need to be pushed a little bit and do more.
Yeah, you mentioned bone quality. How important is that as the surgeon during the surgery and afterwards in the recovery?
Oh, it's critical for especially our implant-based operations. So, for some smaller things, discectomies or just decompressions, it's not as big of an issue. But certainly for purchase of the implant, in terms of what that means is how well does it integrate, how well does it hold. You can imagine that almost like putting an anchor or a screw into a wall when you're holding a painting up. How strong is that screw fixated into that drywall? So that's one part of it, but there's also the healing part of it that happens afterwards. So a lot of our fusion surgeries, if you have very soft or weak bone, your ability to create new bone is impaired, and you're going to have a hard time healing that area. It's going to take longer, or it may not happen at all. So really emphasizing optimizing their bone quality on the front end, and then after the surgery is very, very important for us for implant-based spine surgeries.
Yeah. And I forgot what I was going to say. Oh no.
I have that effect sometimes.
Yeah. Oh boy, that's annoying. Anyway, next question. What does the future of spine surgery look like?
Good question. The future of spine surgery, well, it's going to change in a lot of ways. From an educational standpoint, you'll continue to see, I think, more integrated spine programs, more integrated neurosurgery and orthopedic surgery fellowships. Um, you're going to see, from a cost standpoint, a lot of changes happening, more cutting of implant costs, probably more reimbursement cost cutting from an insurance standpoint, just like any other care, any other field in medicine. I think that you're also going to see more of a transition of spine surgery out into outpatient centers. LA is actually ahead of the curve on that, some of the bigger metropolitan cities, but a lot of people are right on par with that as well. So you're going to see a lot of spine surgery that's being transitioned to surgery centers, I think, moving forward. From a technological standpoint, I think that spinal surgery is going to continue to just blossom in terms of AI and robotics. I think I write journal articles on robotics, and I think that technology will continue to just kind of be a big player in spinal surgery as we move forward. So I think that AI will have and computer net-based assistance will definitely have a role that will factor into spinal surgery in the future.
Yeah. How are you seeing that now, and what do you think like the timeline is for that being integrated into everyday care?
Well, it's already here. I mean, we are using robotic surgery sometimes on fusions. If you go to bigger hospitals that can afford robots, angling our screws and mapping things, and mapping screw trajectories, and even the initial steps of placing some of our screws is now helped sometimes with robotics. A lot of surgeons who've been trained how to handle screws and do them on their own are still doing that. But I think that as the technology provides more of a service, we will start to see it being more favorable, I think, in terms of computer-based technology supplanting traditional surgical care. You may see robots in the future who are placing 8 pedicle screws at the same time, or the accuracy is just there and it does it in a matter of a couple of minutes. So there are just things, I think, that as the technology becomes more appealing, will start to supplant traditional methods. I think right now they're just so comparable that the investment is somewhat dubious for the surgery centers, for the surgeons. But as that technology grows, we're going to see that being, I think, more commonplace in everyday operations, as opposed to just, every now and then at bigger institutions.
Yeah. Would you also say that it's kind of moving toward like the minimally invasive kind of thing, like with most other surgeries?
Yeah, I mean, again, that also plays into going into surgery centers. If you do have a huge surgery and the patient is in terrible pain, it's hard to do that in an ambulatory center. So surgery is always moving towards minimally invasive techniques, and that's really something that's on a spectrum. We have all kinds of ranges of technologies that we consider to be kind of quote unquote minimally invasive. So you will see, I think, that to continue. But a lot of things have been in place for the last 15, 20 years that I would consider minimally invasive surgery. But I think that will continue. There's more and more endoscopic techniques that are coming out for spinal surgery. There's more of an emphasis on that. That may kind of tie in, I think, with surgery center-based spinal care, doing smaller camera-based operations. But time will tell. We'll see kind of what happens. But yeah, absolutely. I think if you can achieve similar effect through minimally invasive techniques, that's always going to be favorable for people.
Yeah. What do you think, like you mentioned AI and robotics, what do you think the role of the spine surgeon will be like in the next 20 years? Is it going to be like an overseer? Is it going to be non-existent? Like, how does that look in your opinion?
Yeah, in my opinion, yes. I think the spine surgeon will always be there to be a secondary check. And there are things that a robot will not be able to do initially, decompressions and, different fine motor tasks that I think are really difficult to ask of a robot right now. But as the technology advances, it's going to be able to do more and more things that that it's currently not able to do, that will take over, I think, the role of the surgeon. So we will kind of be more of a secondary check to the robot in some ways, and more of a quarterback to the operation, making sure everything is going well, and doing some of the finer things that maybe the robot can't do.
All right, that's encouraging. What about for like other fields of surgery? Do you think that that's also going to hold true for like the surgical oncologist or the neurosurgeon or something like that?
Yeah, I mean, I think that, anything where you have technical dexterity, fine motor, 3D spatial stuff, that's all things that I think are very difficult to master in the field of robotics, and the decision making in terms of how to do that right, and do right by the patient in those settings. So I don't think that, um, I think that we'll be the last people to be supplanted in medicine, basically, if that happens. But, but I think that there will be some shared role. I think it'll be kind of a symbiotic relationship between the two.
All right. That's what I hope for with the future of AI. Like it's uncertain. It's hard to plan, but
Yeah.
I think we're smart enough to not have Skynet become a real thing.
Yeah, exactly. So, yeah, I think we'll be taking maybe a couple steps back in the next several years, but you have to have somebody there that is just a second pair of eyes to make sure everything's going right.
Yeah. Let's talk about quickly some prevention, which is what I remembered I was going to talk about. Uh, for someone with reduced bone quality, what is something that they can do to either prevent the degradation of their bones or just like bring it back up?
Give me.
Hello again.
Hey, sorry, we got cut off, but I'm back. All right. So I'm sorry. What was the last question?
For someone who has either deteriorated bone quality or it's like going down, what can someone do to bring it back up or maintain their robust bones?
Yeah. The main things are going to be making sure that you have adequate calcium and vitamin D levels. The other thing I would say is basically putting compressive forces through your bones, which basically means doing some light weightlifting. So if you have, elderly parents or grandparents, you want to encourage them to do at least some light weightlifting to improve bone mineral density, and avoid that frailty factor as much as they can. And then the last kind of bucket of things you can do is, if you are really in the lower category, what you can do is, we have certain medications or anabolic agents that really help boost up your your bone mineral density. So those are really the three big buckets, I would say, in terms of helping with bone density.
Would you recommend weightlifting to someone who's like 65 or older, or like in kind of the elderly category?
Absolutely, I would. Yeah, I would definitely recommend it. You don't want to do something that's going to hurt you. You don't want to push beyond your capacity, but absolutely, for your bone health, it's important to do some weightlifting if you can tolerate it, or even some some calisthenics and even body weight type exercises is great for your bone density.
Yeah. And I don't know how much of a role this plays in spine surgery, but impact aerobics, I think, or I've heard, is something that's super encouraged for bone health. I don't know how you would do that on your back, but yeah.
What is impact aerobics? I'm not sure I know what that is.
Like if you're running, like you strengthen your shin bones, or if you're like punching a wall, you're strengthening your radius neuron on your hands and stuff.
Yeah, that's basically Wolff's law. So any compressive force you put is going to help with that. So you can go and running. I mean, you transmit an axial load. I think things like even air squats, core strengthening exercises, even, anything you do with your extremities, you have to actually stabilize your core too. So there is some kind of directional forces that are impacted and pass through your spine too.
Yeah. How important is core stability for like maintaining a healthy low back?
It's really important. Yeah. I mean, like I said earlier, one of the three things that we talk about with our patients is going to be core and paraspinal musculature strengthening through physical therapy. That's really what I tell people is kind of your long-term play in your stock portfolio. It's like your Apple or your Microsoft or your Amazon, things you hold on to for a long, long time, your blue chip stocks, so that um, you know that's what's going to help you in the long run. So core strengthening and paraspinal strengthening, all those things not only help with your bone quality, but they also help to offload some of the forces that your back has to endure.
Yeah. What do you think about like deadlifts and heavy squats with the bar on your back? Because
Good question. Yeah,
yeah, as we just talked about, like that could help strengthen like the bones, but
yeah,
you see all these injuries of people like
yeah.
disc herniations and
I think you have to. I think you have to be really careful with those exercises. I think that you know deadlifting specifically, I think, is kind of a dangerous exercise. It basically takes where your center of gravity is and puts it way over the front of your core, and so that puts you in a very mechanically disadvantaged position, and is predisposes you to having low back injuries. And so we see very high level deadlifters who, even though they have probably good form, you're just repetitively doing an exercise that puts you in a mechanically disadvantaged position and is, going to predispose you to injury. So I don't usually recommend deadlifts for my lumbar patients, and squats is a little bit better because you're staying over your center, but it does certainly increase your. It's a balance, right? If you're doing heavy squats all the time, then you're going to be putting a higher load repetitively through a lot of those lower discs that you have too. So you have to kind of balance that with your core and paraspinal strengthening.
yeah, and even from like kind of a broader view, you can mess up your knees, you can mess up your hips, you can do all sorts of
Sure,
things.
sure.
Yeah, but as you said, it's about that balance because
Yeah,
it is a healthy thing to do, just not all the time.
right, right. So,
Yeah. And going back to core strengthening, do you recommend kind of like the crunches and the sit-ups or some kind of isometric core stability, or what does that look like?
yeah, I mean, it depends on the functional capacity of the patient. Some of these patients can't do a push-up or they can't do some of these things. So we usually put that into the hands of that's where our physical therapy colleagues kind of come in and try to devise a exercise regimen for these patients. A lot of times I recommend something called the McKenzie back exercises. You can do them at home, and they're kind of a validated exercise kind of cluster of workouts that you can do. And there's, meant to be helping people with those kinds of muscle groups.
Yeah, absolutely. What advice would you give to the aspiring spine surgeon right now?
Um, Advice in what stage of life are they in right now?
Um, let's say, how about we give one set for a pre-med, one for med student, and then one who's going into fellowship?
Okay. Um, for the pre-med, I would actually say, and even for the medical school ones, I would actually say, you know, open your blinders a little bit. If you're already in that stage and you're like, I'm going to be a spine surgeon, you know, I would make sure that that's really the right space for you and that you've gotten enough exposure and that you've seen the tough side or what I always say is you have to pick a field that you can handle the bad stuff or the dark moments of that field, and that is okay for you. You can't like I used to love primary hip replacements and knee replacements, but I couldn't deal with revision, replacements when they had to come in and get corrected or fixed, or they were loosened or whatever. And that's a lot of what a joint replacement surgeon does. So I was like, I can't be a joint replacement surgeon because, that's not going to jive with what I'm interested in. So I would say open your blinders. Make sure that you've given every field its due, diligence, due the respect that it deserves, because they're probably going to change your mind. So find out what it is that's actually important to you. Find a few fields that kind of correspond to that, and then find a good mentor that you can kind of tag along with and really dive deeper into that and see if it's the right fit for you. So that's what I would say first, is gain some more superficial level experience with someone who's been there in a very deep level before you're saying, I'm going to be a spine surgeon. For the people who are going into fellowship for spine surgery, I would say do as many or be involved in as many cases and surgeries as you absolutely can. Round on every person, be there to help with every complication and get your hands into everything you possibly can, because you're learning at someone else's, basically, on someone else's dime, let's say it that way. That there's no high stakes pressure on you, but you get that firsthand learning, so that when it's your patient, you know exactly what to do. So, in surgery, reps is, I think, one of the most important things.
Yeah, absolutely. And for any skill,
yeah,
it's super important.
Yeah, the learning curve is critical in any specialty, or any kind of training that you do. Right? It's like flight hours. It's like whatever you want to think of. The more of it you do, the more proficient you're going to be, and the better off you're going to be, and the less uncertainty you have. I was at places, I was very lucky to be in places where we saw a lot of spine, did a lot of spine surgery. We had a lot of hands-on experience, and those kinds of things make sure that you're ready to go when you're on your own.
Yeah. And for someone who's maybe not so sure, would you also say, like, get your hands in as many cases or fields as possible?
Yeah, I mean, I think if there's an interest, if there's a spark, then you need to, pull that rope and see where it takes you. You need to see, is this the right specialty for me? And, if you stick around and you really love it, then you found your answer. But I would say try not to pigeonhole yourself so early into such a subspecialized field, and then later find out you've spent all this time in something that you have absolutely, no affinity to, and you really like the idea of it more than the actual practice.
Yeah, that's a huge thing. You like the idea of it rather than the actual field, because people think like, oh my God, neurosurgery. I use neurosurgery as an example because that's, like, I guess, for someone who's not in medicine, like the top tier. Not that neurosurgeons are not the top tier of people, but
Sure.
They come in, they're like, I want to do brain surgery. It's super precise, like minute little things. And they come in, they realize, oh, we're using drills to open people's skulls. We're like vacuuming brain tumors out. Like, it's the idea of it is a lot different than the actual real reality of it.
Yeah, you have to really find I think a lot of people find themselves in medicine. You have to find out how you're wired. I think that surgical oncology explanation, or my story, is really, for me, I found out more about myself than the fields. I said, this is not for me. This is what I need. Almost like I'm looking for a business partner or a spouse or something like that. It's just, you're looking for what makes you happy and can sustain you for the rest of your life.
Yeah. I mean, for me personally, like, I realize that I like to know a little about a lot of things rather than a lot about a little things. So that kind of has been, like, changing my view of what specialty I might choose, but I'm way early in that. So
yeah. So give it time. I mean, you've got a lot of medicine around you in your life, and so you'll have no shortage of opportunities, and take advantage of all of them and do it as much as you possibly can. And I always say, even to my patients, I say, time declares everything. And so you'll find the answer. Just hopefully it's sooner rather than later, so you're not scrambling on the back end.
Yeah. If you had to do your medical training all over again, or you went back in time, you had the option of doing medical training all over again, would you do it again? And if you did, would you change anything?
Wow, that's a really, I don't reflect on that question anymore. Um, I would say, now looking back where I am now, I would say, yeah, I would do it all over again. Um, if you ask me in the health climate, in the in the world that we're in today, or I mean in 10 years, I don't know what it's going to look like for physicians in that market. Um, but definitely today, I mean, I look back and say this is, from a business standpoint, from an ability to care for people standpoint, from an autonomy standpoint, from, taking a skill set and a gift and sharing that with people, all of those things, that having the ability to actually have a sense of purpose within the work that I do, I think is one of the greatest gifts you can have. If you have a job that makes you a lot of money, that's great. But I think it's even more lucky to find a job that gives you a sense of purpose when you wake up in the morning. So I would do it all over again. If I were to do it differently, again, what would I do differently?
If anything.
If anything, I don't think that any of the steps I had, we didn't talk about, I had a very unusual trajectory in my medical stuff, but um, in my career. But I would just say that I always think back and I said, man, I wish I would have asked this person how they did this, or I wish I knew this. And now it's hard for me to do that because I don't have the opportunity. You can't, be a black belt and then go ask white belt questions, right? It's hard to do that. So talking to some of my colleagues, even some of the people in the hospital, from nursing staff to techs to this, asking them how they do this and what, what the, where the what's in the weeds, what are the details there. I wish sometimes that I had asked even more questions than I did. And I consider myself an inquisitive person.
Yeah. If you want to quickly uh recall that journey, you said it was unusual, if you wouldn't mind.
Oh yeah, I can give it to you in the Cliff Note version. So um, yeah, I came out of high school and I was going to go to a few different places, doesn't matter where, but I ended up getting into a program that was like a 6 or 7 year combined program. I don't know if they even have these anymore. There were only a handful back then, where you basically go straight from high school and you do a combined program straight through medical school. And so I finished my undergrad really early, and I went to visit my brother for a track meet that he was running at Emory. And I fell in love with the medical school. I went to the school, I was absolutely blown away. And I interviewed with the dean while I was there, and I quit my program and I actually came down and started medical school um, down there. And so I had a kind of unusual uh, pathway there and had the best 4 years, and then went down to Miami and spent some years there, and then happened to somehow come back to Atlanta. I didn't even meet a single spine faculty member while I was there. But anyway, they have like a very top tier orthopedic spine fellowship there. And so I ended up being lucky enough to get to go back there. And I thought I was going to live in the South and I was going to do, a lot of hospital-based work and state-funded hospital care. And then my parents and my brother ended up moving to LA. So then I relocated here and started my own practice to be close to family, but I never saw myself in LA. So a lot of times I consider, medicine to be similar to the military. A lot of things pop up and opportunities present themselves, and you're always kind of being transferred or going to different areas and learning new things. So
Yeah.
it's a great life experience, and everybody's journey is a little bit different.
Yeah. I've heard some people, let me rephrase that. In medicine, there's a lot of twists and turns, as you pointed out. And a common piece of advice that people give is just say yes to as many things as you feasibly can, so that your life just kind of becomes an adventure. Like, how much do you agree with that?
uh, I think if you have no responsibilities or you can kind of go as you please, I think that's a great way to live life. You'll probably be very happy. I think if you have a goal of how you want your life to shape up, if you want to be in a certain area, if you want to have a certain practice or model of medicine that you're sure that that's what you want to do, then I think you need to actually tailor it a little bit more to that while still keeping your eyes open. But I love that approach. And I think in medicine, you have to be a yes man or woman. You have to, if something comes up, you have to explore it. But you have to also be able to have discipline and self control and say, okay, this opportunity is not for me, or it is for me. And then kind of go down that certain flow chart or that tree, that decision tree. You can't just be pulled in 100 directions and be the master of none. You have to kind of know yourself, know what makes you happy, and follow that tree to the last branch.
Yeah, that's a great line. Follow the tree to the last branch. Thank you so much, Dr. Ghasem. I really appreciate you being here and interviewing with me.
Thanks, man. Yeah, thanks for having me, and I hope to see you soon.
Yeah, thank you so much.
Have a good one.
Bye-bye.